And mainly it is heart disease, ischemic heart disease, cardiomyopathy, peripheral vascular disease, and cerebrovascular disease. As you all know, the absolute risk factor of myocardial infarction is much, much higher in diabetics compared to non-diabetic patients, and usually it can occur also as a silent MI rather than your normal patients. And it has been shown in many slides. One of them is shown in this slide that was published in Diabetic Care in 1993 that shows that people with diabetes have a higher impact. And it's not only the occurrence of myocardial infarction in diabetics is more prevalent than non-diabetic. Also, it has been shown in many studies, like the one we can see in the slide, the MERT study that was published in Diabetic Care in 1993, that showed if you compare the mortality from a cardiovascular attack or an MI, if you compare diabetic with other risk factors like hyperlipidemia or smoking or hypertension, the diabetic patients will have a higher mortality from myocardial infarction compared to other patients. This wasn't the only study that confirmed that diabetic patients can have higher mortality rate compared to non-diabetic patient. Also, if the patient have prior MI or non-prior MI, the factor of being diabetic will increase the chance of mortality. This is also confirmed by a New England Journal of Medicine publication in 1998, which shows that you have a higher tendency, as you can see in the slide, to have a higher mortality if you are diabetic with a prior MI compared to non-diabetic patients. In the other study that is published in the Archive of Internal Medicine in 2001, the T2DM, for more than 15 years, they were following more than 121,000 patients, women mainly of age 30 to 55, they had a higher chance of coronary heart disease with diabetic compared to non-diabetic patients. And if we compare individual with diabetes or without diabetes, if they have MI or non-MI, the study that is published in Circulation in 2004 that you can see in the graph, if the patient does not have diabetes or prior MI, the calculated death from non-fatal MI is around 3.9% compared to 32.2% if he had diabetes with MI. If he had diabetes only without prior MI, the chance is also around 10.8. So you can see the much higher chance of mortality if they are diabetic with an MI compared to non-diabetic patients. They estimate that the risk of ischemic stroke, if we go to the other part of the body, which is the brain, they estimate that the risk of ischemic stroke in diabetic patients will be 2 to 3 folds increased in men and 2 to 5 folds increased in women who are diabetic compared to non-diabetic patients. And also the recurrence of stroke will double if the patient is diabetic compared to non-diabetic patient. Stroke outcome will significantly be worse if the patient is diabetic compared to non-diabetic patients. Diabetes and peripheral vascular disease, it's usually a clinical manifestation that will include ischemia of the lower extremity, impotence, and intestinal angina. The true prevalence of peripheral vascular disease is usually difficult in patients with diabetes to determine because most of the patients are asymptomatic until they develop complication. If you age adjust, amputation rate in diabetics is around 8 in 1,000 patient years, with a prevalence of around 3%. The incidence of gangrene foot in people with diabetics is 30 times higher in diabetics compared to non-diabetic patients in an age-matched control. And therefore, assessing your patient peripheral circulation is very important in the patient visit. You can do that by the capillary refill. You make sure by his temperature, arthropathy, and arteriobrachial index. The ABI indicate. If it's normal, it will be more than 0.9 to 1.2. If it's claudication, it will be between 0.5 to 0.9. Critical ischemia is usually less than 0.5. And if we look into the study that we have been talking about since the beginning of the lecture, ischemic heart disease and coronary artery disease is the third most common complication that occur in diabetic patients in Saudi Arabia, of around 23%. And usually it will occur between 12 to 15 years from the time of diagnosis of diabetes. And therefore, the ADA recommendation for statins, which is the mainstay for prevention of coronary artery disease or peripheral vascular disease, is to control diabetes, hypertension, and hyperlipidemia. And therefore, the use of statins and in the treatment of diabetes, if it's less than 40 with no risk factor for coronary artery disease, you evaluate annually by a lipid profile. If he's in the age of 40 to 75 with no cardiac vascular disease risk factor, he is in a moderate to high recommendation for statin, and you need to monitor his adherence. If he is more than 75 years, if he is with no risk factors for coronary artery disease, then it's moderate. If he have risk factors, then it's moderate to high. And if he have a coronary artery disease, then it's high recommendation that you start your patient on statins. Statins therapy should be used to reduce cardiovascular risk in adults in type 1 and type 2 diabetics following the following features. If he is more than age of 40 or less than the age of 40. If he's more than age of 40, then start the patient statins. If he's less than age of 40 with diabetes for more than 15 years, or age more than 30 in diabetic type 1, microvascular complication, then they are warranty a treatment with statins. The target for dyslipidemia treatment on those patients is, as you can see, according to the American Diabetes Association, the primary target is to decrease the LDL below 2.5 millimole, which is around 100 milligram per deciliter. In patients with known coronary artery disease, secondary prevention, then you push it furthermore to decrease the cholesterol below 1, an LDL between 2.5 to 3.35, which is around 100 to 129 milligram per deciliter. If you can't reach that, so you might use fibrate or niacin, especially in patients who are intolerant to statin. The Canadian guidelines say that the LDL should be lower than 2, which is 77 milligram per deciliter, and secondary target non-HDL will be less than 2.6, which is less than 100. or an apolipoprotein B level of less than 0.8. And you can see this is a very busy slide, but you can see very clearly the table which will describe the target of dyslipidemia treatment with diabetes in an adult treatment panel. Now we will move on to the aspirin treatment for the recommendation in diabetic patients. Aspirin of 75 or 162 milligram per day is recommended for secondary prevention in diabetic patients with history of MI, vascular bypass, stroke or transient ischemic attack or peripheral vascular disease. Aspirin 75 milligram is recommended as primary prevention in any patient with diabetes with an increased cardiovascular risk, 10 years risk of more than 10%, which would include most men aged more than 50 or women aged more than 60. If you have a patient diabetic aged more than 50 or a woman aged more than 60 with an additional cardiovascular risk factor like smoking, like hypertension, obesity, or albuminuria, or a family history of coronary artery disease, then it is recommended to use aspirin in those patients as primary prevention. So let's repeat this again. If you have a patient, when can you use it as primary prevention? If you have a patient who is male more than 50, female more than 60, with another risk factor that is like smoking, family history, hyperlipidemia, then use aspirin, please, as primary prevention. Aspirin is not recommended for diabetic patients under the age of 30 due to the lack of evidence of benefit. Aspirin is contraindicated to age 21 years old or below due to the increased risk of Ray's syndrome. Plavix, or 25 milligram per day, is recommended in patients with coronary vascular disease and documented aspirin allergy. So what are the vascular protection checklists? First, check your hemoglobin A1C. You need to keep it around 7 or less. Blood pressure control. You need to keep the blood pressure below 130/80. Number 3, cholesterol. You keep LDL below 2. If indicated, then you move on the target furthermore. Drugs protection. You have to always think, does your patient need statin? Does he need ARB or ACE if he have macroalbuminuria? Is aspirin indicated? This is like your checklist in every visit. Exercise, eating healthy. You make sure that your patient exercise in a regular basis. And don't forget that to try to help your patient by emphasizing that he needs to do smoking cessation, which can be helped by medication those days. And you need to convince your patient that this is one of the most important factors to prevent complication that he can have from diabetes. Just to consolidate everything we have said and to recap all the importance factors of decreasing the complication of diabetes, remember that your diabetic control is the main target. It has been seen in this slide with an elegant study that was published in New England Journal of Medicine in 1993. Since that time, it has been shown that all the microvascular complication can be decreased by diabetic glycemic control. So you can see the hemoglobin A1C, the worse it is, the higher chance of relative risk of developing microcomplication. This is also have been proven in UKPDS, that every 1% drop in hemoglobin A1C, it can reduce diabetic complications significantly. Like lower limb complication, it can be decreased by 43%. Microvascular disease by 37%. Cataract complication by 19%. Heart disease, myocardial infarction, and stroke can be decreased by 16 to 12%. This is what you should advise your patient. Your patient should understand very well that every time he comes to the clinic with a drop in his hemoglobin A1C by even 1%, he will decrease significantly the chance of complication. You need to have this graph with you in the clinic. You need to show the patient that every 1% have a very significant meaning in his life.